Thank you, Susan. Outstanding job. Next, we have a couple gentlemen from the other side of the pond, from the UK, Dr. Andrew and Dr. Michael Swart. They're with a healthcare system and hospital in Devon, I believe, and they work with the NHS, and they have done a learning process to understand from patients and staff how to fix fractures quicker. So look forward to hearing from these guys. Thank you.
Good afternoon. We're at the end. Hey. Andrew, this isn't the right talk. Very sorry. We could do this talk, but this is the one we did at our workshop. But I think you might have put up the wrong slides. So we did a workshop, a pre-meeting workshop, and I think, well, I know this is what we did at the workshop. We have a different talk that hopefully will come up very shortly. No, but the last time something similar to this happened to me was we were doing a primary trauma course in Kenya, and the power went out. And there was no backup, and but we were prepared for that in Kenya. We weren't prepared for that. This is a lovely picture of Torquay Harbour, but it doesn't actually reflect Torquay at all. We're at the bottom of England, in the southwest, and while our weather isn't quite as good as New Orleans, we do have better weather than the rest of England. As a consequence, we have quite a lot of immigration of elderly patients. This talk comes in two parts. I'm going to deal with what we did to changes in our hip fracture pathway, and then Andrew's going to do the second half and go through, well, actually how we did it. First of all, a bit of importance. Usually I put up UK data, but I looked up last night American data. You have 350,000 hip fractures in your country a year. Your mortality is very similar to ours. 30-day or in hospital, 10 to 15%. At a year, it's somewhere between 20 and 30. It costs you a lot of money. I'm going to focus, or we're going to focus on changes in our pathway that were primarily to reduce the time from the ER to the operating room. Also to reduce the pain before surgery. Now, we've spent the last 7 years altering our surgical pathways, and we've been very successful. We started with something which we used to call enhanced recovery, a form of fast-track surgery, but very much based around the patient's needs. And we cracked it for all of our elective or planned surgery. But over that 7-year period, we struggled to implement change for hip fractures. Our old pathway involved multiple handovers of the patient from one care worker to another. It was not planned. It may have evolved a bit over the last 100 and 150 years. It was also thought to be based around what's best for the patient. But I'm not sure we ever looked at whether it was best for the patient. It also was accepted practice across the whole of the UK, which made, I think, making the changes more difficult. This is the old pathway put very simply. Starts with a patient in primary care, who a phone call is made, either 911 or a family practitioner, rings a paramedic with an ambulance to come and collect the patient, take them to the emergency department. The handover is from the paramedic to a nurse. The nurse then hands over the patient to an emergency room doctor. Various tests are done. If it is a hip fracture, they're then passed on to a ward nurse, ward doctors. The treatment is usually put them into bed, and somewhere between 24 and 72 hours after their admission, they have the definitive operation to fix their broken hip. It doesn't look that good. I don't know if it's better in your country. I expect in some areas it may well be, but in others it's similar to us. This is our new pathway. It starts with the paramedic rings the hospital and contacts the trauma nurse to say, I've got a patient with a fractured neck of femur or hip fracture. It's not difficult to diagnose at least 80, probably 90% of these clinically, and a paramedic can do it. You have a shortened externally rotated leg, and once you've seen it, you know what it is. The trauma coordinating nurse then starts planning the patient's surgery from that phone call. And it's simple. She or he thinks, are we going to be able to get that fracture fixed today? On arrival to the emergency department or the emergency room, the handover is from the paramedic to the trauma coordinating nurse, which cuts out the emergency department completely. They again start preparing or thinking, is an operation possible? They take